Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
It's Lindsay Smith-Rogers. More than 5 years after the start of the COVID pandemic, Dr. Alba Azola continues to see patients in her long COVID clinic at Johns Hopkins. Today, Stephanie Desmon talks to her about who's still impacted by long COVID, what we've learned about its causes, and why more research is needed to better understand treatment and prevention. Let's listen. Alba Azola, thanks so much for joining me.
Thank you so much for having me, Stephanie.
So the topic today is long COVID, and I feel like it's something that we don't talk about a lot anymore, but it's still a real problem for a lot of people. So I'm wondering if you could sort of paint a picture of where we are.
Yeah, very much so. I think people were so eager to move on from the pandemic that the public coverage and interest in anything COVID has been lingering and going away. But it is very much of our issue, as we know now that about 10% of people that have an infection with SARS-CoV-2 present with lingering symptoms. And in some of these cases, the lingering symptoms can be quite debilitating, and the ability to continue working, to do their day-to-day activities. And those patients that started with long COVID symptoms earlier in the pandemic, there's a subgroup of them that are still quite impaired. And as you know, people are still getting SARS-CoV-2 infections. So we are seeing new onset of long COVID after multiple SARS-CoV-2 infections.
So what are the symptoms that we're seeing?
I would say the predominant symptom is fatigue, severe debilitating fatigue. Along with that, we also see cognitive impairments. People describe it as brain fog. It's kind of like not being able to think clearly, issues with memory, issues with sequencing, and issues with spatial arrangements as well, like visual spatial orientation. Other than that, we definitely see a lot of symptoms of orthostatic intolerance. And this just means difficulty with being upright, getting lightheaded, dizzy, feeling palpitations. That is a very predominant symptom as well.
How do people know that COVID is the source of these symptoms?
Right. And that is such a tricky question as we move on from the pandemic and people are not even testing, not really knowing if this was a COVID infection. And sometimes you can also have asymptomatic infections where you may have had the virus but not shown any symptoms and develop these lingering symptoms afterwards. So it truly is a clinical diagnosis at this point. And we have the National Academies of Science and Engineering and Medicine develop a definition for the case. And it's truly any symptom that presents after a SARS-CoV-2 infection and is present for at least 3 months. So it is a big umbrella definition, and it does encompass a lot of potential presentations, but it truly is based on clinician-driven interview and really trying to tease out the timeline. And in some cases, there were symptoms that were present before, but have been exacerbated by the SARS-CoV-2 infection. So it definitely can get muddy in terms of giving a final diagnosis.
And there's no actual test for it.
To this date, we know a lot more than we did 5 years ago, but we still don't have biomarkers that can reliably, give us a clear diagnosis.
I guess that must frustrate patients.
It frustrates patients definitely, and also clinicians. It's very difficult for clinicians to feel confident about giving the diagnosis of long COVID. And often people shy away from that, which in turn makes it difficult to be able to really have an accurate estimate of how many people are suffering from long COVID. Extremely frustrating for patients, because patients themselves sometimes don't want to think of them as having long COVID, right? It's a little bit of a controversial diagnosis. So some patients may not even want to do long COVID. And a funny story is that when we were doing a research study looking at cognitive impairment and disruption of the blood-brain barrier in patients with long COVID, we found ourselves with our first batch of data that some of these patients that were volunteering as SARS-CoV-2 infected but fully recovered actually had long COVID and they just didn't realize it. So we had to start incorporating different questionnaires and screening procedures that would help us tease out who really didn't have long COVID and who had it.
We must know more about it now. So, do we get a better understanding of what's going on biologically? Is it possibly an autoimmune cause at this point? What can you tell us about what we've learned?
We've learned so much since the pandemic started. And I think one of the main things is that post infectious chronic conditions are not a new thing. So long COVID is not as brand new as we thought. However, historically, these conditions have not been well funded. There hasn't been a lot of research going into them. So we kind of started behind the science. We were not very advanced there. So to this day, we don't have clear pathophysiologic mechanisms that are resulting in these clinical presentations. However, there are main pathomechanisms that are thought to be playing a role, and there may be more than one. So autoimmunity is certainly one of those mechanisms that it's being studied, and we have identified several antibodies against proteins in the human genome that are basically attacked or by molecular mimicry. These antibodies can attack our own bodies, but they were produced against the virus. Basically, it's what molecular mimicry is. So we do see that this is one of the pathways, as well as we see it in other post-infectious conditions. We also understand that there's some immune dysregulation and actually hyperstimulating of the immune system. We also see that there is damage to the lining of the blood vessels, and this also causes this potential for microthrombi, or this small little micro clusters of platelets they're calling them microclots in the literature, and also direct damage to the nervous system, specifically peripheral nerves. So it is still unclear, but we know that there are certain mechanisms that are certainly part of the clinical presentation.
Are patients getting better?
Excellent question. I would say that to this day, we don't have a treatment that can cure whatever is happening. And I think it's a result of not having full understanding of the pathophysiology. However, there are many ways that clinicians can help patients improve their quality of life and function better. So I would say that there is a group of patients that have long COVID at 3 months post-infection that will improve within a year. And there's data to support this. However, there is another subgroup that continues to have severe symptoms at 2 years, at 3 years. So it depends. You either get better within that first year or you may continue to have debilitating symptoms.
I know that you've been doing research and others have been doing research. I know also that there have been cuts to research. Is this something that is continuing to be supported, or is there a question there?
Initially, it was very exciting having resources put into long COVID, which attracted people that could push the science forward, that were doing work in other fields, that then got interest in this post infectious world of research. That has certainly been more limited now in terms of calls for proposals and such. So there is that concern about how to keep that momentum and how to keep the science moving forward. The NIH does have some funding for the Recover Initiative, which it's a cohort study, which is ongoing. And now it has a treatment part, which is the Recover TLC. That has reserved funding for specific clinical trials. And that's great. But the funding for the mechanistic trials, that is a little bit harder to come by, and that has to be funded in order for us to actually get where the clinical side and the research side meet, and we get those answers that we absolutely need to help the patients.
You mentioned that in the past there have been diseases that have then morphed into the type of long symptoms that we see with COVID. What are some examples of that?
Yeah. I mean, you can think about long Lyme. or post-treatment Lyme disease. There's also long EBV or long mono. That was something that during the 80s, there was some big waves and a lot of interest on that presentation. Unfortunately, back in the 1800s, this type of presentation was described as a psychosomatic presentation. And that perception from the 1800s has persevered throughout history. Every time I learn more about the history, it makes me more frustrated because back, for example, in the 1950s, there's beautiful descriptions of outbreaks of similar post-viral syndrome in Punta Gorda, Florida, and in London, a Royal Free Hospital. And you can see how there was this initial interest, and then a couple of 10, 20 years later, the history kind of turns around and goes back to the old view of this as a non-organic issue. So we're hoping that this wave continues and just try to keep all the research engaged and the funding coming so that we can disrupt that cycle and really get the science to catch up and be able to give the answers the patients need and deserve.
I feel like people have forgotten that these folks exist. Do people still get long COVID? Do they get it less frequently? What's the current situation?
What the data has shown is that the initial waves or the initial strands of COVID had higher rates of resulting in long COVID, and that has gotten better. However, there's multiple factors. We know that there's herd immunity. We know that there's vaccination, that there's better treatment for acute COVID that is available. So that the answer is yes, the numbers are less, but the answer is also they do continue to appear with new cases. So I've had patients that their fourth infection was the one that triggered the lingering symptoms. So it is certainly happening. I think the numbers are down, but I also think that it's important to emphasize that this can happen in your fourth, fifth, sixth infection as well. So it's something that cannot be put to the side, and it needs to be present in the public mind when they think about COVID.
And what do you see going forward? Do you see there'll be maybe treatments? Do you think we'll get a better understanding of what's going on?
Yeah, I'm super excited about the future, not only for long COVID, but also for the tens of millions that have been suffering with infectious from their long EBV that they have been suffering for 20, 30 years. So it's an exciting time in the field. Funding is going to be a key part to procure so that we can continue the efforts that are needed and maybe securing funding for periods of time, so similar to what happened with HIV, where there was a commitment of 10 years of this funding. So we need to see that type of effort. I think the community and the activism in those people with long COVID and other post-infectious illnesses have been amazing. And these patients push beyond their limits in order to continue to keep the awareness and the political pressure in order for the government to prioritize this issue. So I definitely want to remain hopeful, but I also don't want to fall back into repeating history. And I think the community knows that. And that's why there's a sense of urgency in trying to maintain these efforts.
Alba Azola, thank you so much for joining me.
Of course, it was a pleasure. Thank you for bringing this topic and highlighting the importance of this.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharpstein, Lindsay Smith-Rogers, and Stephanie Desmon. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.